Hello, I am Dr. Perry E. Jones, and I am a private practitioner in Richmond, Virginia. I also serve as an associate professor on the adjunct faculty at Virginia Commonwealth University School of Dentistry. I am an associate professor in the Department of Oral Maxillofacial Surgery, as well as an associate professor in the Department of General Dentistry. This case presentation, the first in a comprehensive three-part series examining the advantages of these tools, will demonstrate how orthodontic treatment can be used prior to surgical intervention to reposition teeth, correct the occlusion, and establish the restorative space needed for the eventual implant restoration. A healthy 60-year-old patient presented with a non-contributory medical history. The patient's chief complaint pertained to her maxillary anterior fixed bridge, which had become loose and was on the verge of falling out. She was also concerned about her worn-down, crowded anterior teeth, especially her malpositioned lower incisors. Examination revealed multiple posterior crowns and restorations. The patient reported that her ill-fitting, failing maxillary bridge was delivered as a temporary solution by her previous dentist after she lost one of her canine teeth that was supporting the original restoration. The 6-unit bridge was essentially a wire-reinforced acrylic appliance that was anchored only by the remaining canine and central incisor. Her oral hygiene appeared satisfactory, and radiographic examination revealed minimal loss of crestal bone density. Although the panoramic radiograph confirmed a hopeless state of the maxillary canine and central incisor, there was sufficient bone for an implant restoration. While the patient was indicated for implant treatment, her mandibular anterior dentition needed to be straightened and lowered by approximately 2 millimeters in order to create the vertical clearance needed for restoration. Tooth movement with Invisalign clear aligners was the first step of a comprehensive prosthetically driven treatment plan. Intrusion and rotation of anterior teeth are strengths of Invisalign treatment. In this case, the clear aligners helped position the lower incisors in the proper vertical position, correct the patient's occlusion, and reduce the functional forces generated by the eventual implant restoration onto the opposing dentition, preventing the future wear of the patient's teeth. After completion of orthodontic treatment, the incisal edges of the lower teeth were restored with composite restoration. Several objectives to the orthodontic treatment plan for the mandibular anterior dentition. The lower canines and incisors exhibited significant attrition, likely due to occlusal forces. Over time, as the incisal edges were worn, the anterior teeth had extruded such that the vertical appearance of overbite deepened to a 60 to 75%. As part of the treatment, tooth-colored composite resin forms, called attachments, that control tooth movement were attached to the teeth to precisely fit the reservoirs of the planned series of plastic aligners. An Invisalign feature called Power Ridges was added to the lower left lateral incisor. This feature uses a labial dimple in the aligner to create a movement force that adds root torque in the lingual direction of the buccolingual plane of resistance. The treatment plan for resolving lower anterior crowding was to use interproximal reduction, or IPR, to maintain the overall position of the teeth in the arch form with no expansion or procline movements. In the maxillary arch, where tooth movement was not needed, the treatment plan included extraction of the remaining hopeless anterior teeth, which were eventually replaced by the anterior implant bridge. Because the maxilla exhibited an anatomically correct ovoid shape, and there was no significant rotation or movements desired for the remaining posterior teeth, the treatment plan called for preserving the original form of the upper arch and the positions of the remaining maxillary dentition. The goal was to maintain the edentulous span of the 6 anterior teeth canine to canine. A thermoplastic Pontic appliance was fabricated in office. This included the use of composite resin to fill the span of the missing 6 anterior teeth. The plan to maintain the maxillary arch and prevent any tooth movements was verified using the ClinCheck software. After extracting the patient's remaining maxillary canine and central incisor, the maxillary thermoplastic Pontic appliance was seated as well as the first in a series of mandibular Invisalign aligners. This allowed healing of the extraction sites and execution of the tooth movement treatment plan to occur simultaneously. The aligner attachments were closely observed and monitored in visits to ensure proper seating of the aligner attachment reservoir. Orthodontic treatment produced the desired results: tooth movements. The ClinCheck predictions for anterior intrusion estimated a reduction of the anterior vertical appearance of deep bite from 75% to a more reasonable 25%. The post-treatment intraoral images illustrate clinical results that mirror the virtual plan, including successful intrusion of the mandibular incisors. The desired rotation of the anterior dentition needed to resolve the crowding issue and correct the occlusion was also achieved. Stay tuned as we illustrate the higher levels of accuracy and the precise prosthetic outcomes that can be achieved using digital technology and CAD/CAM prosthodontics.